Hi, we're Group 2, and we're going to discuss modifications to mindfulness-based cognitive therapy to make it an inclusive and accessible mental health intervention for all populations.
Mindfulness-based cognitive therapy is a branch of mindfulness-based intervention that combines the techniques and benefits of cognitive behavioral therapy and meditative practices from the mindfulness component of Buddhist tradition. Developed by Teasdale and colleagues, MBCT has been shown to be an effective intervention for major depressive disorder, specifically in preventing relapse of recurrent cases. Its focus on MDD and challenging the repetitive negative thought process associated with the disorder is what sets MBCT apart from other MBIs. As a treatment, MBCT is most beneficial to patients who have experienced 3 or more MDD episodes and have been shown to improve mindfulness scores associated with lower stress and mood disturbances in cancer patients, meaning its positive effects on well-being may be generalizable to wider populations. Our interest in this specific MBI is due to its connection to a well-established cognitive intervention such as CBT that could help target MBCT to broader audiences who may not have explored mindfulness in the traditional cultural space it is found. Moreover, we believe the use of CBT in combination with MBI can provide the tools necessary to use mindfulness effectively and safely. Using mindfulness as an intervention for mood disorders that involve negative thought processes, rumination, and self-blame can very easily set participants up to be pushed out of their window of tolerance. This describes the limit within which an individual can effectively and safely cope with an issue without entering a state of fight, flight, or freeze. CBT teaches participants how to challenge their thinking patterns, which may seem contrary to mindfulness, but a first step in this is being able to notice unhelpful thought patterns. Mindfulness practice provides the space to notice our thoughts in a non-judgmental way, a tool taught through CBT that can prevent our minds from becoming overwhelmed when acknowledging negative thought patterns. MBCT is typically structured as an 8-week training program with 2-hour weekly sessions of 8 to 15 participants per group. The length of this program is necessary to teach participants the foundations of mindfulness and CBT. The amount of hours of practice for a week is based on the positive correlations found between length of practice and level of mindfulness. Thus, more intensive programs may be used depending on case severity. The structure of MBCT programs is designed to give participants the tools to use the practice on their own, increasing the longevity of the benefits after the 8-week period. One consideration of MBCT is the high degree of motivation and commitment it requires. While learning the foundations does not pose a huge obstacle for most people, the takeaway is individual practice that requires commitment to regular practice and use in moments of need. Regular practice allows the application of foundation learnings to one's own thoughts, continuously strengthening that non-judgmental reflex towards our negative thoughts as we attempt to reframe them. Eventually, success in this regular practice can lead to a reliable set of tools to apply towards our thoughts in moments outside of our window of tolerance. The motivation needed for independent practice can pose a high dropout risk in this type of intervention.
All right, so now that Sam has gotten into the background of MBCT, I'm just going to talk about the approach of the program as well as its strengths and weaknesses. So, as Sam touched on before, MBCT is a mindfulness-based intervention that essentially adds a component of mindfulness to cognitive behavioral therapy. The approach of this program involves utilizing mindfulness practices such as the body scan, yoga, and sitting meditations to help patients with accepting their negative, uncomfortable, or intense feelings. Along with this practice, the CBT component of the program gives patients the tools necessary to notice when they are having unhealthy thought processes and detach themselves from these processes, or to redirect their attention to their momentary real life experiences. And as Sam explained, the aim of this MBI is to prevent relapse or recurrence of depressive episodes among patients struggling with major depressive disorder. This is a very severe and life-altering disorder, and while the program has been proven to be effective in some cases, there are certainly strengths and weaknesses of it that I will now be getting into. So MBCT is a program that has both its pros and its cons. One strength of the program is that it does appear to be significantly effective in preventing relapse of depressive episodes in patients who have had more than 3 depressive episodes in their life. However, a program being particularly helpful for members of certain groups has its downsides as well. In addition to being less effective for patients with a history of less than 3 depressive episodes, MBCT is also less effective in those who are not as prone to ruminative thinking and those whose depressive episodes are preceded by major life events. So it seems as though MBCT is a pretty targeted and specialized program. It is not designed for those who are acutely depressed, and it is possible that they will actually have more difficulty with maintaining the focus and the attention that is needed to get the most out of this program. So, this is a large subset of people that are struggling with major depressive disorder that MBCT may not be the right treatment for. So it does appear that MBCT may be a program that is most helpful to a specific subgroup of people with MDD, but it may be the wrong treatment recommendation for many others. However, there is another strength of the program in that it is cost efficient, as it only involves group therapy in an 8-week time frame, which is far less expensive than a one-on-one cognitive therapy for an extended period of time. So this means that it is more accessible than individual CBT for low-income patients. But one last weakness of the program is that it is still a relatively understudied treatment, and there's just more research that is needed to confirm the benefits of the program. So while there are definitely benefits to MBCT, it's also important to acknowledge the limitations of the program and to encourage more research into the benefits and the mechanisms involved.
Finally, let's discuss the modifications to improve the current mindfulness-based cognitive therapy program. Throughout the past 30 years, MBCT has been extensively studied to provide scientific evidence on its effectiveness as a valid treatment for mental health. In fact, the 2021 systematic review and meta-analysis by McCartney et al. Highlight that MBCT is more effective than the typical treatment plan in preventing relapse of depression, demonstrating its ability to improve mental health. Despite its benefits, MBCT remains inaccessible to the vulnerable populations, which is defined as patients who are racial or ethnic minorities, children, elderly, socioeconomically disadvantaged, and uninsured, or those with certain medical conditions. As stress and anxiety are often triggered by stress, people in lower socioeconomic classes are more prone to suffering from mental illnesses without receiving the necessary medical support. Thus, our group poses these 3 modifications to the current MBCT model to improve the mental health outcome for all people, regardless of their backgrounds. Foremost, we urge the World Health Organization, a trusted international health agency, to clearly define and differentiate the various MBIs, providing research-based information on these programs in layperson's terms. Currently, the facts about MBCT are scattered across different platforms, and scientific evidences are only available in scholarly articles. As there is no concrete source that clearly describes the detail of the programs or its benefits, this is incredibly confusing and misguiding for the general population who will not know what evidence to believe or trust. Although there is information about mental health, MBIs are not listed as a solution nor has its own page on the World Health Organization's websites. Thus, summarized information in everyday language will allow the public to become aware about MBCT. Secondly, a governmental website listing the MBCT clinics and their financial assistance programs is critical to increase accessibility. One may argue that this may be costly, using too much of taxpayers' money. However, according to statistics posted by CAMH, the disease burden of mental illness and substance use in Ontario alone is 1.5 times higher than all cancers put together and more than 7 times that of all infectious diseases. Thus, governmental funding towards an MBI portal that provides citizens with credible mental health resources will be actually alleviating this burden on the healthcare system. If we were asking to make an informational governmental website for physically visible illnesses like cancer or cardiovascular diseases, people wouldn't question its purpose or necessity. Thus, we should provide the same level of love and support for invisible illnesses like anxiety and depression. At last, just like COVID-19 vaccination portal, the government should make websites to list all available MBI resources in each geographic region, and this website should highlight insurance coverages and bursary funds to allow individuals to be more aware of their financial situations and resources. Lastly, group session formats should be mandatory for all MBCT curriculum in both online and virtual settings. In the MBCT intervention study conducted by Gares et al. In 2020, all the participants provided positive feedback about the group format. In fact, they expressed that the group environment was a good opportunity to normalize their thoughts, feelings, and how they relate to these, helping them to realize that their negative feelings and discomfort are part of a shared human experience. Although in person programs are inclusive of these benefits, virtual classes lack the community experience. Thus, it should be written into these programs to utilize the breakout room features in online settings, allowing participants to converse with one another to share and relate to each other's experiences. Additionally, this new regulation will ensure to minimize the disparity between offline and online settings. Ultimately, our modifications to MBCT would provide an accessible mental health intervention for even the people in the vulnerable population. Thank you so much for listening to our presentation, and I hope you guys all have a mindful day.